So I'm going to transition us to our project updates. So for those who are presenting, if you could come join me up here. So all the partners have slides. And so as they come up, I just want to really thank all of them for all the work that they've been putting forward. They've been working really hard, especially these last couple of months. So if we could all give them applause, that would be great. All right, so Heater Road is first.
Hi, good morning, everyone. So to give an update since our last meeting, we've been working hard on our monthly multidisciplinary core team meetings, the MDC team meetings, since May 2018. They're going really well, and so we are just at about a year mark on that, so very exciting. We are using the shared care plans for all of our patients that we have MDCT for. So working with CMT, our vendor, on that, and that's been going really well. And continuing to onboard new patients into this project. What's not up there is that we have currently 6 active shared care plans at Heater Road, and 2 or 3 are pending. So we started with 3 or 4 patients, and we have spent this past year identifying patients and going through eligibility. So that's exciting to see that grow. Our referral stream has been strong. We're working really closely with West Central Behavioral to bring in our high utilizers, our high need patients, to identify them again for this project. And we are going through with the consent process that we spent many months in the early stages working through. And so that's been going smooth. And have even been able to share what we've learned from that process with other project groups. Yes? The Multidisciplinary Care Team, or core team. And so we have included a patient advocate representative to join us during our project team meetings. We were doing bi-weekly meetings as a project group where we've moved to a monthly because things have just kind of hit their stride, which is great news also. But it's been really important to have a patient advocate, somebody from the community who can kind of put themselves in the shoes of the patients we are trying to help. So that collaboration has been really beneficial as well. So I think that is one thing that's not on there actually that I would like to add is that we are starting to bring in other community partners into the MDCT. So we're currently working to get Headrest on board with our meetings and get them integrated with Collective Medical Technologies platform for shared care planning. So that's another accomplishment that is underway. So thank you.
I'm here to talk about our B1 reverse integration project, and I'm here because Chris, our provider, can't be here because he's seeing patients, which is really exciting for us. I think that this has been a really long process to get us up and going. So he is seeing patients. He is embedded in Monadnock Family Services, seeing patients there. You know, I think, you know, when Stephanie asked me to talk, I really thought about there's many lessons that we learned in this whole planning process. And I would say everything takes longer than you think it's going to take. You know, and again, I'm not a healthcare provider. I'm a human service background person. And so for me, it felt kind of simple. Get some money, hire some staff, do some work. And there's so much minutia that needed to be really looked at and planned for. And we really needed to sweat the small stuff. And what we also recognize is we didn't really have all the right people at the table early on. And when we're thinking about providing primary care service in a different location, there are many processes that needed to be in place, like point of care testing. I don't even know what that was. So how did I know to think about what needs to be in place from a systems perspective, from a credentialing and a licensing perspective. Something really simple like, okay, we need to buy an exam table. Okay, buy an exam table, get it delivered. We had within inches of space to get it into the room. And again, we didn't think about in planning to measure the exam table and make sure it was going to fit through the doorway. And again, it's a simple little thing, but there was a lot of minutia things that we really didn't take into account until we started getting really close to seeing patients. And I'm really happy to say that we're seeing patients. Chris has got about half a dozen patients that he is seeing on a regular basis. The ACT team at Monadnock Family Services is really actively engaging referrals to Chris now. And as we suspected, the word is getting out. So we are finding people who historically really were less than likely to see a primary care provider in our clinic are now reaching out to their case managers and saying, I haven't seen a doctor in a long time, and I know you got Chris at your building. I really want to see him. So I think there's really positive wins, and I think by the time we come back for our fall meeting here, we'll have lots of really good data to tell you.
The first thing I want to say is I'm so happy that this day is today and not a month ago, because a month ago, what you see would not be up here. What I can say in hindsight and to those projects that are moving forward is sometimes you will hit speed bumps and you will put on the brakes and you will freeze and you will paralyze because of the barriers that you see. And sometimes they're real barriers and sometimes they're perceptions, but you have to keep driving through. You have to keep having conversations like, what is it that we need? What is stopping this progress? And actually having people on your team identify what those things are, because it makes a tremendous difference. And as you start breaking those things down, then you see the progress. And so 30 days later, I can stand up here and show you this slide and say, we meet one Tuesday, the first Tuesday of the month is the Valley Regional Only team, where they identify things specific that are going on in the practice. We meet the third Tuesday, that same team, and then we bring in our community mental health partners, counseling associates, and West Central Behavioral Health, and we work on logistics on the whole project. We have now welcomed a community health navigator, what some of you call a community health worker, we're calling our community health navigator, who is navigating through some of the barriers that the patients see on the community level. So Lexi has joined us. Krista, who is our MSW social worker, she is really got her feet under her now, and she is meeting with patients, and we're actually finding the other practices that we haven't rolled out to now, they've gotten wind of it, and so they're trying to backdoor kind of refer in, and so now we're actually having to say, whoa, slow down. We will eventually roll all this out to all of the practices, so that's been great. We have had 5 successful months of MDCT meetings for the adults, where by the end of this month we will have rolled out the pediatrics project to one of our practices, and then by the middle of June, we will have had both adults and pediatrics across all practices, all providers. And we keep describing this as a faucet, that we're not going to turn the faucet all the way on, we're going to slowly just keep opening it so that everybody understands and doesn't feel overwhelmed that we're rolling it out to everybody, all providers, all patients, all the time. We have our CCSA. We've created for the adults, we've created one for youth, and we've created the parent CCSA for that youth coming into the pediatric office. We have created, Valley has been in a journey of EMR transition. For some of you in the room, you know what that's like, and you have this project and you want to be able to report on the results, but your EMR doesn't allow that. So we have created an enhanced database that all of that information gets stored in Excel in a particular way that does totals and all of that kind of stuff. So we have a sound system to be able to record. And our team has overcome numerous logistical barriers to achieve success. That's been the last 30 days. of which I will say that I'm glad it's over with because it creates a lot of stress. And then the other thing, being project coordinator for both Valley and Newport, what I have watched is it has given a tremendous benefit for two separate entities to share information, and especially with the CCSA process. Valley started their project, brought the CCSA to Newport. They saw that tool and said, oh, you know what, we should do this, we should do this. Well, what about this? I brought it back to Valley, and they're like, oh yeah, that's great, and we could also do this. So by those two groups going back and forth, they have created such incredible tools that it could never happen in a silo on its own. So my suggestion for you, if you're in that process of creating things, reach out to another IDN and share back and forth and get the input of the other ones, because there's so many things that in and of yourself, it looks like you've got it sound, and then somebody says something and you say, well, that was a no-brainer. Why didn't we think of that? And so there's a great sharing capacity that could go on as well. So that's Valley.
So I'm Erin, I'm from the Newport Health Center, and I apologize, I was trying to throw this together yesterday when I was not at work. So, but we started our project in pediatrics, I think because we felt like we really needed a challenge. There's an extra layer of things to think about when you're looking at pediatrics, so it was really difficult, and we're still working through some kinks. But, and we do work very closely with our with Stacy over at it's great. It really is amazing. So what we've done so far, we work with the pediatric population 12 to 18 right now, doing the CCSAs. It's been, pretty amazing. We've learned a lot about families that we really didn't know. And our physician champion it says right there, it's reported positive. She just was really great at talking about our other providers when we introduced this to the whole provider practice, saying that we're gonna have to do this with everyone. They were a little stressed about that, but she said she was sort of resistant to it at first because it sounded like there was a lot of extra work, but she said it turned out there isn't a whole lot of extra work for her to do, and as Kelly said, she now knows when she gets these things back, she has someone she can hand them off to. She has a social worker, she has a community health worker that can address these problems instead of her just saying, good luck, sorry that you don't have housing, but I can't help you with that. So we've been really, it's just been great. So we are supposed to roll this out with the rest of the practice probably by June 30th. I think. Definitely by June 30th. But I think we're going to be able to do that. We're going to be pretty busy, but I think that's about it, really. Any questions? Good.
So Monadnock couldn't join us this morning. It is quite the drive from Peterborough. They, like many others, are going through a lot of transitions right now, but they are prepped and ready to go to implement the CCSA in 2 of their practices. And they're choosing to do an entire practice and not focusing on payer type. So they're planning on putting it out to all patients that walk in the door. The unique thing about Monadnock is they have an internal behavioral health department that already works very closely with their primary care. So it's a unique opportunity with its own unique challenges.
Okay, so our project also rolled out to general internal medicine at Dartmouth-Hitchcock. So working with this group, things have moved along quite quickly in comparison to our rollout at Heater Road, which was our pilot. So we are meeting as a project group bi-weekly. Those meetings have been going on since last summer. We're working on our current state mapping, our process mapping for the workflows around identification and referrals for shared care planning. GIM has implemented the CCSA for 3 out of their 4 teams in GIM. They're planning to do another rollout soon by July. And so that is something that is very new, and so still working on what that flow will look like in terms of capturing that data. The good news is that GIM was able to recently hire a CHW, a community health worker. So that person has been really excellent and right on top of it, picking up those SDOH high scores, as it were. We have had 3 MDC team meetings completed thus far. We have another one next week for GIM. We've had a lot of really positive feedback from the providers on the team that we are working with right now. 2 of our providers are actual PCPs for the patients we are discussing at these meetings, have been able to attend pretty regularly. So that's been a really nice positive outcome, that they feel this is valuable, that this is a good use of their time, and have gotten a lot out of it. We've been collaborating with West Central for all of these meetings, both at Heater Road and at GIM, so big shout out to West Central for making themselves available for all of these meetings. We meet monthly, and so I run these 2 meetings currently. And so that's been really, really valuable. I also should add that I sit over at West Central 1 day a week, and so I attend weekly meetings with the team leaders, the ACT team, and the Enhanced Care Program team leaders, and it's been a great collaboration, a great way to be communicating about candidacy for this project, and keep everybody on the same page, bridge that gap, and I love it. Along with this, and there's so much overlap with what we're doing at GIM and Heater Road, so I jump back a little to Heater Road here and there, but training for all of this is ongoing. Training providers, breaking it down for various groups within the primary care practices, to kind of teach them how to use CMT, how to use the shared care plan platform. This is something that is ongoing, so we are working on a training tool for our resident group at GIM, so that's the next step. We did do trainings for, their teams are by color, so we're working with the green team right now. And so kind of trying to figure out, you know, as education around this is so important to be ongoing, and wanting to engage providers who are, again, you know, very busy. You know, do we do like a one-shot training, or do we do sporadic trainings? And then if there's sort of those offshoot providers that have a patient that we think would be really valuable for a shared care plan and an MDCT collaboration, you know, do we do a one-off and kind of train them? So much coordination. It was mentioned, I mean, just the minutia that goes into all of this coordination, and just getting to the point of holding an MDCT meeting, and having shared care plans that are you know, a value add for the providers to take their time to review, is an ongoing process. So I'm really excited to see how quickly we've been able to kind of pull things together at GIM in Lab. It's been really exciting to just feel like, okay, we learned so much this past year from our work over at Heater Road, and you know, just to be able to kind of parlay that into this new group that's really a huge group, it has been really wonderful. So that's my update. Thanks.
My name's Colin from Alice Peck Day. I'm representing actually many of members of our team today. In about 48 hours, our organization is going to be going live with a new electronic health record. Epic. Is anybody familiar with that bay? I am. Admittedly, we have been a little, our focus has been shifted a little bit. However, we have still been able to make some gains since our last meeting. One thing that I'd really like to just highlight that we really were really concerned about, but turned out okay, was actually hiring a behavioral health clinician. We went into this, we posted the position, I believe, a couple of months ago, maybe about a month ago or so. And all that we had heard was that it's going to be difficult to find a behavioral health clinician. There's a lack of them around. And I don't know, maybe the stars were in alignment, but we had 4 or 5 applicants immediately that we had the opportunity. So we felt blessed. So we have hired a behavioral health clinician. They will be starting with us shortly. We're very excited about that. The timing just seems to work out so well with the implementation of our new EMR and being able to start moving forward with a lot of this CCSA work. We will be piloting shortly after we go live, and once our behavioral health clinician starts. We really felt it was important to have that person in place and oriented before we got started. We've also started to review our shared care plan options and starting to put together our multidisciplinary care team. So starting to move that work forward. We're doing it little by little, but hopefully we can start to reshift our focus here and really start to make some really great gains. So, thanks.
I'm representing a co-pilot project, which is a partnership between Cheshire Medical Center, Dartmouth-Hitchcock-Keene, the Service Link program in the Monadnock region, and Monadnock Family Services, which is the lead for this project. And I'm just going to say, I think it's an amazing project. I think we actually rolled out the project in January of 2018. It's been, like everybody else, ups and downs, but we have a steady stream of referrals from Cheshire Medical Center. We have a stream of referrals from the clinic, and we have had staffing shifts, but we have a full team right now, an incredible team of 4 care coordinators and a part-time referral coordinator at Cheshire Medical who's on the floor part of every day. And it's just, it's really it's great to watch it really starting to work. We've created some HIPAA compliant workarounds in terms of our workflow, but we have a way of getting all our data from Cheshire to Service Link and to the mental health center in a secure HIPAA compliant way, and are really excited to have a shared care plan at some point. Good enough?
I am with the Moms in Recovery program at Dartmouth-Hitchcock, and I've been said to talk fast, and that's not a problem for me. It's so nice to hear everybody else has had bumps in the road. We had big bumps in the road at the beginning. Our intensive outpatient program has been up and running now for a little over a year. We started last February, and to date, as of the end of March, we had only 9 people complete the program. As of the end of this week, we'll have 11. We currently have 10 women enrolled in the program. We are seeing our challenges are, what we've done since we last met, we have MOUs with Mascoma Community Health and Red Logan, so we're bringing dentists in to do initial evaluations of the women and their dentition, which has been really wonderful. They're coming in a couple of times a month and fast tracking them in for services. We also have MOUs with WIC in both Vermont and New Hampshire, and they're going to be coming into our program to meet with women there to sign up for services and for ongoing follow-up. These are places that women have a really difficult time getting transportation to, so it's nice to have them on site. We have, I think another challenge that we're seeing right now are, we're fully staffed, which is also great news. We're seeing increasingly numbers of women coming in. I'm doing evals with them with stimulant use disorder and alcohol use disorder. I haven't done an eval with somebody who's just been an opiate use disorder in quite a long time. So it's the addiction issues are more complex, and people aren't tied to that prescription, that MAT coming in and getting that prescription. So that's also been a challenge. We have, if you build it, they will come, and now we are bursting at the seams. Our spaces, it really a big challenge. We had 12 children in our very small play space yesterday. It's great news that we have volunteers and people to take care of the children, and we're bursting at the seams, and our rooms are not adequate to take care of as many patients as we have right now, which is also another challenge that we have. Where everyone except one person who's completed our program, our intensive outpatient program, has stepped down to twice a week, so they continue on in care with us, which is really nice. Many women need higher levels of care for many reasons. They're not wanting to go into residential care, and we're continuing to work with them around that. Any questions?
Thank you, everyone. So I just wanted to take a quick moment. There is another project that we don't have a slide for today, but there's an E5 Enhanced Care Coordination project that we've talked about at this session previously that takes place in Sullivan County. It's a meeting of about 40 different organizations who have kind of come to the table quarter after quarter to really start to dig into what's needed in the Sullivan County area in terms of enhanced care coordination, what's available in terms of de-identified case sharing, and how do we kind of streamline the referrals. So I just wanted to acknowledge there are many of the participants of those sessions in the room here today, and it's been a tough process, but I think they've made great strides and are continuing to kind of clear the way for what might work in the area. So thank you to all of them. And then also to many of our partners here today. We talked a lot about the workforce funds and what they've been able to do, and the partners working in the workforce space at the last session. We didn't have time for that today, but again, wanted to acknowledge everyone who's here, who's also doing that work behind the scenes. We're so fortunate to have such a great body of project work at this point. I think we probably could have heard a lot more from all of them, but thank you all so much.